and start that right now. All right. I think we can get started.
Awesome. Awesome. Sorry, I'm over here just laughing because I printed something last minute and the printer is just like freaking out and won't stop adjusting. So hopefully it calms down and you all can't hear it on my side. But yeah, like Nicole said, I'm Dr. Danica Woods. Not quite sure who all is out there. I can't necessarily see anybody, but hopefully you can all see me. I am a naturopathic doctor here at Natural Medicine of Denver. Here is our website. So if you are not yet a patient of ours, we would certainly love to work with you. I'll just kind of intro real quick, the Natural Medicine of Denver website. At the very bottom of the right-hand corner of the first page, there is a little pop-up conversation button that connects you to our HIPAA-compliant messaging platform called Clara. That is the best way to get a hold of us if you are interested in working together. Certainly, I kind of pick and choose who I want to have the Dutch test completed for. So, may not necessarily apply to every patient case, but I do run it really often. I'd say my most kind of typical patients. I work with a lot of women. I work with a lot of women who are going through hormonal changes, whether that is the very beginning of cycles. I work with teenagers, young women who are already kind of struggling with their cycles, all the way up to post-menopause, people going through menopause. Hormones apply to a lot. So we're going to go over all of that information today. I do also do the Dutch complete test on men. So it's not just women. I've seen a lot of really valuable information for my male patients as well. So yeah, not just women, but I did kind of design the slides and everything. It is October. It is Breast Cancer Awareness Month. We will kind of talk about where some of that can kind of show up within the Dutch test. And yeah, let's just kind of dig in. So first page here, just kind of the agenda of what I'm going to be talking about. So the Dutch test really does allow for me to see information pertaining to the sex steroid hormones. I typically consider those estrogen, all of the estrogens, progesterone, and then the androgen. So that's kind of these first two sections here. The third section, we're going to talk about kind of the second part of the Dutch test really looks at adrenal gland function. So looking at cortisol and cortisone, kind of that active stress hormone, not the fight or flight epinephrine or norepinephrine, but I'm aware that the tiger is stalking me kind of hormone. And then the last part that the Dutch Complete has to offer is this organic acids test, or the OAT test, organic acid test. That's the acronym there. And this really just gives us more information about some of the nutrients, a couple other really interesting factors. Yeah, it's a really useful part of the test, especially when considering all of the hormones, how they're created, some of the cofactors needed. Yeah, just a lot of really good stuff. So this is more of a deep dive talking about all of these hormones. Rather than just like giving you a bunch of information, I opted to create this slideshow with case presentations. So I'll show you a couple real results for folks. And I do want to just kind of thank all of my patients who have allowed me to not only recommend Dutch testing, who have completed it, but also allowed me to interpret it and really kind of move forward with their health and healing. You guys are my greatest teachers. So, okay. So first off, estrogen and progesterone. All right. So this is the very first page of the Dutch test. And what you'll see is I took a screenshot of just the estrogen and the progesterone. What we're specifically looking at is the estradiol E2. There are three major forms of estrogen in the body: estrone E1, estradiol, which is E2, and estriol, which is E3. So you can kind of hear the one, the diol, and the triol, the 1, 2, and 3 in those words. And estrogen is really actually, let me back up a smidge. All of these hormones that we're going to be talking about, with the exception of melatonin, all of these kind of 17 steroidogenic hormones is the typical overarching term. They are all they all work intracellularly. So what they do is they go into our cells, they actually go into the nucleus of our cells, and they change the way that our DNA functions. They change what's called the transcription and translation of our DNA. So what that looks like is new proteins are created, different ways of healing, different inflammatory cytokines, different things that we actually see presenting on the body. Cause hair growth, cause muscle growth, cause skeletal system growth, cause cardiovascular system rejuvenation and revitalization. So they work intracellularly, but they do have kind of global widespread effects. So estrogen is the kind of like female hormone. It's what we typically think of for females. And it does have a lot of actions on the reproductive organs of all of the females out there. Um, Really involved with menstrual cycle, also works in conjunction with progesterone for pregnancy. Estrogen is what we think of when women go through menopause. So what we see is drops of estrogen, drops of the ovaries actually being able to create this estrogen. So we see things like hot flashes, decreased libido, decreased sex drive. Um, Estrogen is also present in men, and it is involved with sperm maturation, so sperm production, and also supporting a healthy libido. Globally, estrogen is really important for the skeletal system, the nervous system, and the cardiovascular system. So when women go through menopause, this is often when we start seeing bone issues arise, like osteopenia and osteoporosis. Same thing can happen for men, but women have had this for a very long time. Before they go through menopause, that's when it kind of starts becoming a bit of an issue. Progesterone is often what we like to call like the queen hormone. So produced in definitely large amounts in women in particular, but men also have a little bit as well. Progesterone is what causes the growth of the endometrium, causes the tissue that if pregnancy does not occur, if fertilization does not occur, and implantation of that fertilized egg, this is what is shed every single month. So progesterone really comes into play during the second half of the cycle. Now, when I'm looking at the Dutch test, one of the first things that I look at is what is the balance between estrogen and progesterone. The sample report here is something that I don't actually frequently see, where progesterone is great. This shows for me that someone had this sample patient had a cycle that they did ovulate. But what I usually see, and what you'll see in the next couple examples, is pretty significant estrogen. One of the most common things that we see is an estrogen dominant sort of picture. So let's go a little bit into the cases. Okay, sample report real quick. So this is all of the numbers that you see. So this is all on page 2, just a little bit more specifics of the ins and outs of estrogen, of the primary estrogen. So estrone, estradiol, estriol, and also a little bit more information on the way that these things are broken down. So they go through liver metabolism, which we'll dive into. But this is just what we see happening with these different estrogens. So, kind of taking a look at, okay, these things are below luteal range or within luteal range or at low ends. And that for me is really clinically important. Okay, sample cases. We'll skip over this one. So my first case is a 25-year-old female. She is on OCP's, oral contraceptive pills, and reports really low libido. So this is one of the contradictory things. So estrogen and progesterone, these are both depleted in this patient's case. And what is happening there is, because she is on an oral contraceptive, she has naturally low estrogen and progesterone, what is being produced by her body, because what she's doing is taking a daily pill that has a little bit of not biosimilar, but synthetic estrogen and synthetic progesterone. So her receptors in the nucleus are actually getting filled. Her body's like, okay, I guess I don't really need to produce any because those receptors are getting filled on my own. This purple range here for both E2 and progesterone, this is the postmenopausal range. So when I talk to all of my patients, especially, my 25-year-olds, the gals who are not necessarily going through menopause and they see numbers at this, I say, nope, it's really expected. And it's because of your oral contraceptive. It actually means that it's working really well. This is what we see on page 3. And over here where I've got this little box, that's actually where the androgens go. So we'll dive into that here in a second. But this page is really important for me because it shows more information about not only the total amount of estrogens that my patients have. So E2 being the most predominant estrogen for a woman who is premenopausal, hasn't gone through menopause. But this shows me a little bit of what's going on with liver metabolism, what's going on with these different pathways here. How is she breaking down her estrogens? And is it potentially in a more inflammatory way? Or what you can see here, kind of small, and unfortunately I can't zoom in, but it says protective pathway. So are we producing more of the protective estrogen metabolites, or are we creating more of the inflammatory estrogen metabolites? Down here at the bottom, what you'll see is this note: if not detox.
Dr. Woods, I don't think we can hear you. Can you check that you're not on mute? Dr. Woods, can I interrupt you for a minute? I think you're on mute.
Want to join in real quick and just tell me the last thing that you heard?
Yeah, I think it was about 2 minutes ago.
Oh my gosh. Oh boy. Oh, and I can see, yep, things coming in with the chats. Okay. Let's see. So Nikki said last thing I heard was about the bottom right corner of the previous slide. Okay, got it. Let's go back. Okay. So bottom right corner of the previous slide. Thank you all for letting me know. I'm going to keep my video up, or all of this up so I can see that. Okay, so for OHE1, so this red pathway here, what this is telling us is that, rather than going down this protective estrogen pathway, the one that's eventually going to support the skeletal system, the cardiovascular system, the nervous system, we might actually be going down this pathway, which is more reactive. You can see the word reactive here. Quinones, they bind to DNA, they cause DNA damage. there is some evidence that, maybe these estrogen metabolites, these breakdown products of estrogen, are associated with or impacting breast cancer. So that's kind of where that information comes from. And what is and the part that I'm kind of looking at here, making sure for all of my patients that we're really supporting, especially because naturopathic medicine, we are one of our tenets is prevention. We want to prevent serious disease from happening. We want people to be as healthy as they can be, for as long as they can be, until the body starts getting old and kind of wearing down and breaking down. I want that process to be really graceful for folks. So if one way that we can help support that is by really decreasing these 4-OH inflammatory estrogen metabolites, I'm on board. So this patient, my 25-year-old female, on an oral contraceptive. So even though she's got low estrogens, the way that she's breaking them down is a little bit inflammatory. She's got 18.3% here, and the expected percentage is really important for me too. It's showing us, okay, maybe we're preferring a little bit more of this CYP1B1 pathway, creating a little bit more inflammation. How do we work on tamping that back? So I actually have kind of a before and after for one of my patients as well. Kind of fun to see. Okay, y'all can still hear me, correct? I'm gonna assume I haven't got another message, so hopefully things are good. Okay, thank you. All right, so back onto my PCOS patients, which you didn't hear. So I like running Dutch tests for all of my PCOS patients, probably majority of them, unless they've already had a Dutch test completed with other providers. And the reason I like doing testing with PCOS patients for these different hormones is because PCOS, we typically think of, and PCOS stands for polycystic ovarian syndrome. One of the contributing factors for PCOS is elevated androgens. But when we have elevated androgens, sometimes what I see is different shifts in estrogens and progesterones. So my two patients here, I have a 26-year-old female and a 32-year-old female. They both have pretty similar estradiol here, these E2 numbers, 1.9 and 2.0. But their progesterones are really different. So, this 32-year-old female, she might have had an ovulatory cycle, one where she actually released an egg. And ovulation is often one of the telltale signs of PCOS. There's a lot of follicles produced for some women, but sometimes not all of them actually release an egg in order to get this progesterone. Progesterone comes from the corpus luteum, the spot on the ovary where the egg erupts from. It becomes this endocrine tissue that produces progesterone in particular. So this patient, unlikely that she had an ovulatory cycle, one where she actually released an egg. This patient, it's likely that she released an egg. Okay. And just a little bit more kind of deeper dives into both of these patients. So I've got my 25-year-old over here, my 32-year-old patient over here. I'm going to move the chat just a little bit so I can see these. All right, so what we're looking at here, this patient, like I said, kind of normal bioactive levels of her estrogens. Her E2 looks pretty good. Her E3 looks pretty good. A little bit low on the E1. E1 and E2 are the most predominant estrogens for premenopausal women. E3 is what starts to come in after women have gone through menopause. But diving in a little bit deeper to some of these other breakdown pathways, this patient, and we'll go a little bit into it on the next slide, decent breakdown, not super inflammatory, which is great. Her phase 2 metabolism might be a little bit on the lower side, but not super depleted. This 32-year-old patient, she's got some low normal bioactive estrogens. We can see E1 and E2, those are both on the low side. But going into the next slide real quick, let's just see how she's breaking these things down. So 25-year-old, not creating a whole lot of inflammatory estrogen metabolites, which is great. This patient has 29.3% inflammatory estrogens. So the way that I like to think of these 4-OH metabolites is they're Tasmanian devils. They're going into our cells, they're binding to DNA, they're really just like wreaking havoc. So you can see I've got a very big TAS over here and then a smaller TAS. She's at the high end of this kind of preferred expected percentage, but this patient, we really need to work on backing down on those 4-OH metabolites. And it is possible there are different nutrients that help block that enzyme. There are ways of supporting that really kind of protective pathway. And that's what I talk about when I go over these labs with all of my patients. Okay. Got a 32-year-old female here with heavy and frequent menses, meaning that she's having, periods of bleeding that are really heavy, might be becoming anemic based on the level of bleeding, and having frequent menses. So they're happening, shorter than every 28, 32 days. That's kind of our textbook quote unquote normal cycle phases. So what we're seeing here is what I commonly see in a lot of my patients, really estrogen dominant. When I'm looking at these kind of speedometers from the Dutch test, what I want to see is the gauge being at the same level for all of my patients. So this patient has 10.8, of her, I think it's micrograms of her estrogen that we found with this sample, and progesterone is pretty depleted. She's not in this postmenopausal state yet, but pretty darn close. And what this means is often if she had an ovulatory cycle, she released an egg, that corpus luteum, that spot on her ovary, wasn't enough to produce enough progesterone. So her cycles are happening quicker and quicker. She's really, not having much reprieve from frequent bleeding. So that can be really uncomfortable and definitely impacts people's quality of life. So digging into a little bit more of her specifics here. So like I said, she's got some really kind of dominant high estrogens, these bioactive E1 and E2 estrogens. But when we look at the way that she's breaking these things down, she's got great estrogen metabolism. She's not producing crazy high amounts of the 4-OH Tasmanian devil metabolites. She's actually producing pretty darn close to the protective, the high end of the protective estrogen metabolites that we want to see. So even though estrogen's really high and all of her estrogen metabolites are on the higher side, what we've got is really just like a quick downspout. So liver is working great, but it's working a little bit of overtime because we've got so much precursor. All right. And then, like I said, I do see a lot of women who have gone through menopause, who are going through menopause. So this is a 50-year-old perimenopausal female. Peri just means that she's kind of in the thick of it. She's having some abnormal cycles, but they're definitely getting a little bit more spread out. She's also having some of the telltale signs of menopause, including hot flashes, decreased libido, and a lot of that mind kind of brain fog that a lot of folks will experience. So taking a look at the summary page, estrogen, E2 has started decreasing. Progesterone, she's just right above the peri or the menopausal state, but she definitely needs some support. So this is more of the finer details here of her estrogen metabolism. So especially when women start going through menopause, I really want to make sure we're ramping up this protective pathway, because that is what's going to help support her skeletal system, prevent osteopenia, osteoporosis. Also, reducing the inflammatory is going to decrease potential future risk for breast cancer. So all things that show up for women in kind of menopause oftentimes. So what we can see is that she's got some inflammatory estrogen metabolites, maybe not a whole lot of the protective. Can work on ramping that up. The 16-OH metabolites, as a heads up, they're kind of bioinert. They don't have a whole lot of action. So we want to just make sure that we're supporting the 2-OH pathway in particular. And like I said, E3 starts coming into play a little bit more with menopause. So, if we can support E3 levels, that's the ticket. All right. So I was actually able to do a repeat test on this patient. Really fun to kind of see where things were at before. But what you can notice is that based on some diet and lifestyle change and a couple supplements that she did, for a little bit of time, we were actually able to decrease that 4-OH, and we were able to ramp up her E3 production. So still getting some of that protective estrogen impact, really kind of helping to support, her body creating these protective mechanisms, but also helping to alleviate some of the symptoms that she was experiencing because those estrogen receptors are still getting filled. All right. So like I said, we're going to kind of do a little bit of a deep plunge. I want to just check my time. Deep plunge into metabolism of these estrogens. So I've already kind of alluded to it. These 3 arrows here, you can see this little parentheses here and the star. This is phase 1 metabolism of the liver, kind of step 1 that we take. And the analogy that I like to give is what we are doing is taking these estrogens and we are wrapping them up in a box. So you can see the wrapping paper here, making sure all the edges get nice and crisp. We're putting the tape down. Sometimes we're lining up the patterns. You can get as intense with it as you want. Next step is phase 2 metabolism of the liver. So you can see I didn't want to cover up the COMT or methylation little note here, but this happens in both of these places. So phase 2 is where we're taking this present that's all wrapped up in its paper, and we're tying a bow on top of it. We're putting a bow on, and we're also putting a tag on, and we're saying, okay, this doesn't have too much action in the body. What the liver does is it sends it into the bile, which gets stored up in the gallbladder for folks who have that. And when we eat foods, especially foods that have some fats in them, we're able to release that bile into our digestive tract. So phase 3 metabolism of the liver. Oh, I'm going to just go ahead real quick. Phase 3 metabolism, not of the liver, but of detox is actually having a bowel movement. So that is kind of the final step. So for folks who are feeling a little bit more constipated, they're not having great digestion, that's where this information comes in. Unfortunately, to get kind of more information about how all of that is working, we typically have to do a stool test, not typically tested for with this Dutch test. Okay, let me go back real quick. So phase 2, metabolism of the liver, tying this bow on. We have a couple specific enzymes that we use, most predominantly the COMT enzyme, which is what we call a methylator. So we're adding on a methyl group. We're taking a methyl group from somewhere else in the body, and we're putting it on. That's the tag saying, okay, we're going to pull off this hydroxyl group, the OH, put on this methoxy group, which sends it into the bile, sends it out of the body through bowel movements. So what we're looking at here, and the reason I have some of these little signs here, is I like to think of methylation, the process of putting a methyl group from one place onto this next place, moving the tag from our little storage bin of tags, if you will, and onto this present that we wrapped up and we're sending out of the body, sending through the bowels. I like to think of it as kind of like assembling a model ship. So we're taking one part and piece and kind of processing things over here, and we're moving it, kind of assembling the ship to get it out of the system. When we get the Dutch results back, what's really interesting for me is it's not a genetic test, but these things can certainly be impacted by genetics. There's a lot of folks out there who are researching and have done a lot of great studies on methylation and MTHFR, which is methyl tetrahydrofolate reductase, not a swear word, although it sure sounds like it. What that does is it actually helps transfer the methyl group from one place to the place that we actually want it. if someone has a genetic variation in their methylation activity, what it looks like is trying to assemble a model ship with one broken arm. And even there are four genes that have, sorry, two genes and two alleles for each gene that have control over methylation. So if, three of our alleles aren't working very well, it's a broken arm and a broken finger. So we're assembling this model ship with three fingers when really what we need is both hands. So the process sometimes just gets a little slow, it gets a little sluggish, becomes a little bit of a bottleneck here, where we're getting some backup of the body's ability to break these things down, to go through this process of metabolism. And it slows down for folks. So, like I said, this isn't a genetic test, but does give us a little bit more information potentially on, on genetics at this point, and how well your body does at kind of putting the bow on and the tag on and saying, okay, I'm sending things on its way. All right. And there are things, so going to kind of back to phase 3 metabolism, there are things that can influence recirculation of some of these estrogen metabolites. Most predominantly, there is an enzyme produced by some of the gut microbiome, these bacteria that live in our GI tract, called beta glucuronidase. Beta glucuronidase, I like to think of as the little kid during the holidays who's like, ooh, presents. I'm so excited. I'm going to open all of them, even though none of them have a tag for him. And I guess I'm genderizing, just thinking of some of my cousins who were very snoopy around Christmas. But yeah, what he does is he's like, woo, presents, opens up all of them. We can also think of him as a pair of scissors. He cuts off the tag. And what ends up happening is we have a recirculation back to the liver, back to parent 1, back to parent 2, phase 1 and phase 2 metabolism. And they're like, you're kidding me. I just wrapped up all of these presents. So they're really frustrated. But when that happens, we have a recirculation of all of these estrogen metabolites and other toxins that we're exposed to, just from living kind of in our world as it is at this point in time. So we really want to make sure that we're kind of looking at all of these things, especially for folks who have high estrogen or lots of symptoms of high estrogen. All right. Don't want to forget about our male patients. Estrogen and progesterone, they still come into play here too. So let me give you a couple case samples. So one case, 47-year-old male with some generalized inflammation. When we got his results back, for me, like I said, I'm always kind of taking a peek at what's going on with the 4-OH metabolites. And then certainly what's going on with the 2-methoxy, kind of this phase 1 and phase 2. And phase 1, are we preferring the more inflammatory pathway? So I have a 27-year-old male with anxiety, brain fog, and some fatigue going on. So, like I said, just kind of taking a look at what's going on with some of these inflammatory metabolites, and we do have potential elevation. All right. That was about 35 minutes minus the 2 minutes that I was muted. All right, so let's talk about androgens. So androgens, kind of like the male hormones. So we think of testosterone most predominantly. We also think of DHEA. So DHEA produced in the adrenal glands, testosterone produced more in the sex organs themselves. All right. So as far as the female sample report goes, this is what we see on page 2 and then on page 3. And what we're looking at here is not only, is the body able to take the DHEA, take the testosterone, ends up going into these, the pathway to create these estrogens. So estrogens are dependent on the androgens. But also the way that the body is breaking these things down. So one of the things that we often think of, especially for women, what I typically see is if we have an elevation, so not a great example here, but if we have an elevation of DHT, for women, what that looks like is hair growth here, maybe some acne here, maybe a little bit more aggression. For men, more DHT can lead to some of that male pattern baldness. Women can have that too. male pattern baldness, but a complete beard. DHT is also the hormone responsible for BPH, benign prostatic hyperplasia. So for most of my patients who have male patients who have changes in urination, this is also really helpful information. Okay, so my 25-year-old female on oral contraceptives with a low libido, testosterone is also responsible for libido, kind of low end of range, below range for testosterone, low end of range for DHT. And then some of these metabolites indicate the way that she's breaking these things down. So she's not necessarily preferring a 5-alpha, more androgenic pathway, testosterone to 5-alpha DHT, for instance. But she's struggling with her overall testosterone levels. So it doesn't really surprise me that she's got a low libido, just not interested in that at all. So for us, that's a lot of the work that we're doing together, really making sure we're supporting that. Breaking up my PCOS patients, the first one, 25-year-old PCOS patient. Like I said, one of the hallmarks for PCOS is elevated androgens. PCOS with elevated androgens also comes along with some of the other metabolic changes that we often see. So changes in insulin, changes in blood sugar regulation, increased risk for metabolic syndrome, poor blood sugar regulation, all these sorts of things. So she does have some elevated DHEA. She's got high normal testosterone, but not super elevated. So I was really happy to see that. Her 5-alpha DHT, this more androgenic testosterone, think of testosterone on roids, within range, which is great. But you can see here she does have kind of this 5-alpha preference when she's breaking down her androgens. So for me, especially with PCOS patients and trying to figure out, is the elevated androgens the chicken, or is it the egg? As far as the metabolic changes and the androgens, it's really important that however we can, we're working on supporting moving this arrow back towards the 5-beta preference. 32-year-old female with PCOS, she actually has low testosterone, and not, completely low normal DHEA. She does have a little bit of that 5-alpha preference happening here, but this, for me, is kind of a question of, was PCOS maybe the right diagnosis? And I'm still not sure, because the only change that we're seeing, I'm not seeing any sort of metabolic impact, which is kind of step 2. And then her cycles are the only thing, and they're just happening a little bit more spread out than we would hope for. So that's one criteria. Now I think about it, I don't know if I've done I think she's had a pelvic ultrasound, which is the 3rd criteria. And I don't think she had polycystic ovaries. So anyway, I'm just kind of always questioning what people come to me with. And that's why this lab is so important and gives us so much information. All right, my 50-year-old perimenopausal female, she actually had elevated testosterone. One part of her case that I didn't necessarily share is she actually has diabetes at this point. So, like I said, what is the chicken? What is the egg? Do we always see elevated testosterone in diabetic or insulin resistant patients? Not always, but just kind of interesting to take note of that here. She does have a little bit of a 5-alpha preference. Okay. And this was about a year later. So really kind of making sure that we're supporting, pushing away from that 5-alpha preference, supporting blood sugar regulation. All of these things really kind of help to lower her testosterone, and push more towards breakdown towards that 5-beta pathway. It's kind of so cool being able to see the before and after. All right. I'm going into my male patients a little bit. So 47-year-old male, again, with generalized inflammation. What we're looking at here, so it does look a little bit different from the male to female Dutch results on this page 3. So we actually get to see the 5-alpha DHT as represented through their little speedometer icon here. And this patient, not super elevated androgens. DHEA is a little bit on the lower side. He does have a little bit of a preference towards 5-alpha, the 5-alpha reductase enzyme. So one thing that we're always taking into consideration, especially for male patients, is changes in urinary patterns. Prostate cancer is really prevalent in men, so that's I think that's why I opted to do this test, is because we had seen a couple of those changes, but not anything super worrisome. Just want to work on making sure we're supporting that 5 beta. 27-year-old male with anxiety, brain fog, and fatigue here. He actually has some low normal androgens. So for me, it's kind of a question of, is your brain fog, is some of the fatigue that you're experiencing due to having low testosterone, especially for your age. So really helpful too that Dutch gives us these age-dependent ranges. All right. Number 3 thing that we're looking at, like I said, again, adrenal gland function. So we're really looking at the cortisol and cortisone here. All right. And what I opted to do, so there are often patterns that I'm looking for with adrenal gland function and with cortisone in particular, cortisol in particular. What we're looking for is how well the adrenal glands are functioning. So the way I like to think of what in the naturopathic community we call adrenal fatigue, or in some of the other research out there we call maladaptive stages of stress, is what's going on with your cortisol. Post-COVID, I guess we're still kind of in COVID, it was a really stressful time for a lot of people, lots of grief, lots of uncertainty, lots of change and upheaval, dealing with racial reckoning at the same time, all of these things kind of going on. If it really impacted you, I like to think of really kind of stressful moments of time, like we're driving a car, and rather than our foot having kind of control of the acceleration pedal, the stress that we're under puts a brick on the acceleration pedal. And when it happens, especially if that stress never really seems to calm down, we have projects, we have deadlines, we have bosses, we have traffic, we are moving, we're, like I said, dealing with grief in this post-COVID world, all these things that are happening, we really want to double check what's going on here with this long-term stress hormone. Cortisol is kind of I'm not running away or being actively pursued or chased by the tiger, but it's out there. I need to be aware of it. The thing is, we don't always want to be aware of it. We don't always want to be going 0 to 60 all the time. We want to be able to just coast and enjoy where we're at. So stage 1 adrenal fatigue, or stage 1 maladaptive stages of stress, this is my 25-year-old PCOS patient. She had really high elevated cortisol. So this, definitely high out of range, 24-hour free cortisol. What the body does is it converts it into cortisone. It's the inactive state of cortisol. So kind of putting it in storage, she had some pretty high cortisone as well. So adrenal glands, just 0 to 60. The brick is recently placed on the gas pedal there. So what we need to do is really work on releasing that, because what we end up seeing, stage 2 adrenal fatigue, levels start coming back down. The body starts to maybe convert it a little bit more into cortisone, just to kind of save up for later. But we start seeing the impacts on all of the other hormones. So the estrogen, progesterone, sometimes the testosterone as well. So the brick doesn't necessarily come off of the gas pedal. What ends up happening is we are siphoning off the gas. We're burning through all of the gas. And eventually what that looks like is stage 3 adrenal fatigue, where we're dealing with low progesterone, or low estrogens. Some of these other hormones start being impacted. And then ultimately stage 4 adrenal fatigue. Um, so this is a patient I haven't introduced yet, 33-year-old female with daily fatigue. But what you will notice here is her morning, afternoon, and evening cortisol all on the lower side. Her body's actually converting whatever it has into more of the cortisone because she may need it later. What I like to think of when I look at so this is on page 4 of the Dutch results. We have the 4 samples of cortisol, the 4 samples of cortisone. Cortisol is our top guys in the game, playing the game. Choose your sport of choice: football, hockey, soccer. It's our first string players, our best people out on the field playing. And what we want to make sure of is that we're not benching them unnecessarily, benching them and then ultimately metabolizing them, sending them on the bus home when we actually need them playing the game, because that looks like burnout for a lot of folks. All right. Oh, and sorry, and this is really where kind of all stages of this is where a lot of our adrenal adaptogenic herbs come in. So as naturopathic doctors, we have such a wide variety of herbs that we can choose from in order to really help, take the brick off of the gas pedal gracefully, not, totally removing it. So then we just stop moving altogether. But taking the brick off the gas pedal and then also kind of refilling the silo, filling the gas tank back up. There are ways to do that, either kind of what I would say a little bit more like aggressively, also more gently with some of our botanicals. So that's where naturopathic medicine comes in. And unfortunately, not a lot of providers use this really useful tool. Okay. Last thing that we're going to talk about, and then I'll leave some time for Q&A, is the organic acid testing. And what this is looking for is some of the metabolites that we see based on these nutrients that we're getting in, and some of these other markers that can point us in particular directions. So Dutch actually just added a couple new ones. They added this biotin marker, the neuroinflammation marker, and this gut marker. So if you've had a test with me more recently, you've probably seen these things. If you had a test with me a while ago, unfortunately, these things are not necessarily on those tests, new additions. But what we get to see here is the body's ability to actually use some of these nutrients. We have B12, we have B6, we have biotin, and it's kind of counterintuitive for what we would think. You can see the note here, B12 may be deficient if high. So if this number comes back high out of range, above this 2.5 normal range for the female sample report here, it may mean that we're actually kind of churning up and using way too much of whatever B12 we have. So we actually need to work on replenishing that a little bit. And then the kind of the methylation side of the Dutch test allows me to see, okay, do we need to help support adding in methylcobalamin versus some of the other cobalamin options out there, the cyanocobalamin, the adenosylcobalamin, the hydroxycobalamin. We also get a B6 marker. B12 and B6 not only involved with kind of liver metabolism, but also neurotransmitter production. So they come into play with some of our neurotransmitters, specifically serotonin. Really want to make sure, because oftentimes I will see folks for hormone stuff, but a lot of the women that I see, and even some of the men, they tell me about their mental health struggles, their more anxious tendencies, their more depressed tendencies. So this is where that information comes in handy for giving and getting a more comprehensive, complete look at the person in front of me versus just particular symptoms and incomplete looks. Biotin marker, glutathione, is kind of the chief liver firefighter. So it's putting out a lot of the fires that get caused from producing energy, using oxygen to produce our energy, being in that aerobic state. So yeah, really just kind of helpful information for me here. If glutathione is sometimes out of range, it may mean that we're deficient in glutathione precursors. It's a combination of three amino acids that really help to keep our body out of creating a lot of oxidative damage. We also have kind of a true marker down here of oxidative stress or DNA damage. With this true 8 hydroxy 2 deoxyguanosine marker. Definitely a mouthful. Yeah, I think it's, this test for me is just really helpful in providing a lot of information, not only for my female patients, but also for my male patients, looking a little bit at the circadian rhythm, looking at nutrient markers, looking a little bit at mental health, and if there's any sort of neuroinflammation that's happening. Looking at the way that the body is dealing with creating all of this energy and the oxidative stress that comes along with that. And then from there, it's for me really making recommendations on, do we add foods in? I'm not a huge supplement fan. If I can minimize supplements, I generally tend to. Supplements for me are supplemental to a really healthy diet, clean food, bringing in things that bring you joy, working on stress management, all these sorts of things. So this just gives us a little bit more indication of what direction to take. Which is really helpful because sometimes the body needs a little bit of a push in that right direction. But ultimately, my end goal is that everyone gets back to this place of supporting what we call the vis medicatrix naturae in naturopathic medicine, which is the healing power of nature, and that innate healing power that all of us have within our systems, to kind of get back to this place of balance. All right. So that is kind of the Dutch test, the Dutch complete. Couple other reasons why I love it. Not a blood draw. So for some of my patients who hate blood draws, it is a urine test. So kind of like a pregnancy test, kind of like a keto strip test, or just passing the absorbent piece of paper through the urine stream, or dunking it in if we're collecting our urine, up to 4 or 5 samples depending on if you wake up in the middle of the night, which gives me a really clear look at what's going on with cortisol and cortisone throughout the course of the day. Yeah, it's super helpful. And it shows me a little bit more, not only like what's bioavailable, what's actually being utilized in the body, but how your body is breaking it down too, which is for me one of the most crucial aspects and one of the reasons why I love it. All right, so last page here, just kind of conclusion. So again, Dr. Woods, Natural Medicine of Denver. We do have some other services that we offer here. We do Ayurvedic consultations. That's with our provider, Jessica. She's wonderful. We recently brought on Maggie, who is a nutritionist. So she does nutrition consultations. We do have access to acupuncture. That is through Dr. Rochelle Forsberg, who's the other naturopathic doc here. And then, of course, general kind of naturopathic medical care. So yeah, all of our contact information is here. Our website down here at the very bottom, like I said, you can access our HIPAA compliant messaging platform, Clara, through our website. Looks like Nicole is hyperlinking our website here in the chat, so feel free to click on that, save it to your bookmarks. And then as part of this presentation of talking about Dutch test, we are actually able to offer 10% off of our in-office price for the Dutch test. So looks like it ends 11/30 of this year, so end of next month. So we are able to do the Dutch complete for $324. Our price here otherwise is $360, so it's definitely a good deal. All right, let me go ahead and stop sharing. Hopefully that went okay after that little text snafu. Does anyone have any questions? Let me see if I can open up the chat again. Oh, Nicole, did you want to talk about the last slide again?
Oh, no, it's all good. You did a great job. Yeah,
Okay.
so just so everyone knows that that Dutch promotion is going on through the end of November. So if you're interested in completing the Dutch test, definitely reach out to us and we can arrange that.
Perfect. Perfect. Anyone have any questions? You can throw it into the chat. If not, Dr. Woods really wants to go get some dinner. Okay. All right. So we have a question here. How often should the test be taken or retaken? Oh, that's a really good question. I am definitely clear and cognizant of the financial implications of running this test. So what I generally say is maybe every year. Certainly the 50 and 51-year-old patient that I was working with,